Dr. Rao and Rudra will be talking about their corrections or their suggestions for the methods, followed by Dr. Durga, who will go over it and brief you on it further. Over to Rudra, who can share his screen, and Dr. Anand Rao.
I think let Rudra do the talking, Latika. He's done a good job. Yeah, Rudra, you do the talking.
Yes, I think he is unmuting himself.
Okay.
Yeah. So right at the onset, since this is a clinical trial, there is no mention at all in this entire method section of an institutional ethics review and the approval letter number, which should be mentioned. Also, being a clinical trial, I feel a data safety monitoring board that must have been constituted should be mentioned in the methods, and whether it was a blinded trial, whether it was a open label trial, that should be very clearly mentioned. So going into the specifics, on the first sentence itself, there's a repetition. The first sentence says it's a prospective study, and the second statement again says it's a prospective randomized study. So it can be clubbed into one sentence and probably in a single sentence saying whether there's a control group or not, whether there's a blinding or not. So it can be all condensed into one statement. So something like it's a prospective randomized control open label study, or a prospective randomized control double blind or a single blind study. Following that, I think the inclusion criteria have been mentioned, but what have not been mentioned here are the set of exclusion criteria, which I feel are more important. When a clinical trial is being run, patients who are going to be excluded there's generally a set of exclusion criteria for patients who have transaminitis or some sort of baseline abnormality that precludes their inclusion into a clinical trial. So the exclusion criteria need to be mentioned very clearly, more clearly than this. Next, the definitions of virus detection for chikungunya, they have been enlisted in bullet points here. I would rather have them in a separate section under the heading of definitions, where we define everything pertaining to the trial that we want to have definitions for. So I would make this a separate subsection in the methodology, maybe at the end, perhaps. So coming to this next sentence, it is interesting to note that there were more than 500 patients. So I would avoid such adjectives like interesting to note. If at all I have to make that observation, I would put that in the discussion rather than the method section. And again, greater than 500, it's a very non-specific thing. Was it 501 patients? Was it 50,000 patients? We don't really get any information how many patients actually were there. So a specific number instead of something like a greater than 500 would be better. So next, coming to the next issue, I felt again here using an adjective, unfortunately, during the study period, I would much rather just state how many patients were screened, and the reason for screening a lower number of patients as compared to the number of cases. That is important. I mean, a flowchart here, I think most journals now mandate for any clinical trial a flowchart in which the number of patients screened, the number of patients included, and the reasons for exclusion need to be very clearly mentioned in a flowchart form. So that would be a better way to probably represent this, the screening. So the next issue I had was there are multiple changes to the tense. So right up until this point, everything had been written in past tense. So for example, those who had a history of arthritis and had active disease were already on HCQ therapy, and suddenly it goes on to a future tense. They will be randomized to either HCQ monotherapy or combination DMARDs. So assuming that this is being sent for publication, this trial has already been conducted. It should be in the past tense that they were randomized to either of these groups. Okay. So the next issue I felt here was so again multiple changes in tense from past and future tense that is present throughout this method section. Again, the statement that although all patients had X-rays and feet taken, none of them had any bony erosions, which we presumed was a good sign. So this is again a statement that is better fitted to the discussion than it is to the method section, I feel, because it's an opinion of the author and it's not really related to the methodology of the paper. Again, this statement of whether erosive. Okay. Sorry. Yeah, so this is more like a presumption of the author. It should not be in the methods. So here the outcome measures that have been mentioned, DAS28, ESR or CRP. Again, I would prefer exact numbers of how many patients, for how many patients DAS28, ESR, CRP were available, and for how many patients it was not available and a CDI was done. The authors have just mentioned that it was done in this manner, but not the exact numbers. Again, a flowchart would be a better way to represent this. Again, this statement that a few patients also had their quality of life assessment done, this is a very vague statement to put in the methods. Even if you want to mention that a few patients, I would rather know how those few patients were selected, whether they were sequentially selected from the first patients who presented, or whether it was a random sampling done from the patient population, and the exact number who had their quality of life assessments done. I mean, that would have a direct bearing on the results. And okay, so a lot of tense changes again in this entire section. So from past tense to future tense, there's a frequent change in the tense which should not occur. It should be all in one tense. So again, as you see, both groups of patients will also receive oral or low dose prednisolone. Going again to future tense, that does not make much sense since this trial has already been conducted. Okay. So the outcome measures and when they have been recorded have not exactly been mentioned. So the time points at which these measurements have been done, ESR, liver function tests, and CBC, rather than at regular intervals, I would much rather have something like a 2, 4, 6 weeks or a definite time interval when these investigations were done. Now, in the statistical analysis, I had a few issues. Number one is the computer software. I think the specific software needs to be mentioned. And if it is something like Stata or R, where like the code can be reproduced, then maybe that can be added in the supplementary section where a reproducible code can be put in the supplementary data. Again, here the statistical hypothesis testing, they have mentioned the student's t-test for the continuous variables, which is actually a test for parametric data, and for the categorical variables for proportions, they have mentioned Fisher's exact test, which is a test for non-parametric data. So rather, it would be better to give a generic statement. Key parametric, the distribution of data was analyzed, and we used a t-test for parametric and a Wilcoxon sign rank test for non-parametric data. And similarly for categorical variables, for parametric, a chi-square, and a non-parametric, a Fisher's exact test were used. So something like that would be more prudent, I feel. The sample size collection, maybe in a separate section, we could add the sample size collection. So I think those are my issues with this method section. Thank you.
Thank you, Rudrarpan. It was a wonderful dissection of the method section. There are some more inputs which came in from Kasturi and Srijita. I will just add them along with mine. I'll just be sharing the screen. Just a minute. Is my screen visible?
Yeah, it is.
No, 1 minute. Let me just see. Okay. So I've just clubbed all those suggestions which came in from my team members. Srijita also had wonderful suggestions to give. The same thing that Dr. Ravindran has made it, has done a hard work creating difficult method section which anybody can reject. Thank you, sir. So it has too many unnecessary words and repetitions. And there is, Srijita had this contention that there is no clearly stated hypothesis, no mention about ethical clearance, which Rudrapan did mention. Inclusion criteria are vague, no mention of exclusion criteria. And though they say it's a prospective study, serology results were retrieved, indicate that there is some retrospective component to the same. Method of randomization was not mentioned. Some results and discussion points are included in the methods, which Rudrapan already made. The tense was very confusing. So shifting from past to present, present to future, and the assessments at follow-ups, what were the assessments which are done was not clearly mentioned. And according to me, apart from these nice inputs from Shijita, it is a disjointed method section. They keep jumping from one place to the another with a lot of randomness and a lot of vague statements which were made during the methods section. Kasturi had this, that the abbreviations were used without any elaboration prior to that. And these were I've added Rudrapan's statements too. These were our critique about the method section here. Thank you. Latika, are you there?
Thank you, Dr. Rao. And Rudra, that was brutal but brilliant. And indeed, subheadings are required. There has to be clarity of numbers, and repetition should be avoided, and tense has to be taken care of. Now, Dr. Durga will brief you further on his inputs.
Good evening, everybody. Before I start, I would just like to go back to Rudra and Dr. Rao and just ask, was there anything good that you could find in the methods? We have all criticized the lacunae, but were there any good points, really good points that you could identify there?
For people being initiated, we actually took the critique to the basic word level and we looked at the critical points. I think we didn't pick up the good points. Durga, you should let us know.
Okay, I'll just start with the good points. So for a change, so I'm just sharing my screen. If we see, this is one of the really good points about this. They have very categorically described how sample size was reached, using what assumptions and what dropout rate. Of course, they have still missed something. They have missed the estimates of difference between the groups, but still many people even do not do this. So that in itself is a good thing. And most of the lacuna, I think you have all pointed out very nicely. I would just like to add a couple of points. One is Rudra had mentioned about the outcomes, that various different outcomes were used, and regarding in which how many patients each of these outcomes was used should be described. But overall, such heterogeneous outcomes should be avoided. One should stick to one or two types of outcomes and uniformly assess them across the study, because obviously if you are later going to compare in a patient whose disease activity score was say measured by DAS28 or by the CDI, you cannot really compare the two. A percentage change in the DAS28 is not the same as a percentage change in the CDI, of course. And they may not even categorize patients at the same level of disease activity of low or moderate or high disease activity. So it's best to avoid such heterogeneous outcomes. And the other important criticism was that if it was a clinical trial today, it would require trial registration before the trial was started. Previously, trial registration could have been done even after the trial was completed, but since the beginning of 2019, it is not possible to register trials after they have started. So you must At this moment, if you are planning to conduct a clinical trial in the future, you must register it either with the Clinical Trials Registry of India or with clinicaltrials.gov before you start recruiting the first patient. That is an important thing. I think Rudra might have covered it, but I thought I'll just emphasize on that. Otherwise, most of the points that Rudra has brought out and Dr. Rao has brought out are fantastic, and you have nicely criticized the method section. In case there is anything else that I'm missing, if Dr. Vinod could give any inputs, I really couldn't find anything more to criticize about the method section.
So I have some comments in the meantime. Um Rudra was very brutal about the tense in the paper and the writing. So generally, the most common problem that arises with the tense, and it occurs usually in the method section itself, and is always because you write first a proposal. When you write a proposal, you write it in the future tense, and you describe what you will be doing. And when you finally write the paper, you just copy and paste it from there, and you do not write it again, or you would forget to change the tense. So that's the usual problem that happens, and one which definitely everybody in this workshop should be careful about in the future, so that you don't make that mistake. When we do that copying and pasting, this is the usual problem that happens, and it's very irritating for a reviewer.
Yes, Dr. Goel, I very much agree with that point. That is a common mistake that inexperienced authors would often make, and one must not fall prey to this fallacy of just copying the method section from the protocol. More so with a clinical trial, you definitely have had a protocol before, so it's all the more point to be kept in mind when it's a clinical trial. Definitely ensure that the methods is written in a consistent past tense, because you've already done it by the time you have written. You're writing up the study is already over. Whereas at the time of the protocol generation, you are planning to do it. So you would write that I will do this, I will do that. Whereas in the manuscript, you would write, I have done this, I have done that, etc.
Yeah. Durga?
Yes, sir.
Yeah, okay. Thank you. I think this was exactly, what was intended by honing your skills on this dummy manuscript. So I think this group also has done wonderfully well. What I want to say is that you don't have to be subject expert, to critically appraise a paper's writing aspect, okay, or asking the question as to whether or not sufficient information is there in the method section. So if the beginners in this field want to practice sort of how to pick up the problems, in a given manuscript, it is best to actually use manuscripts which are not related to your specialty. Okay. This dummy paper, and of course also the dummy paper which has been created by Durga, and we used to use one by Dr. Shankar earlier. The workshops are not for rheumatologists. So we have, junior faculty and medical postgraduate students from all the specialties. And the same paper has been used. Okay, all the three papers I mentioned, they are all, related to rheumatology. So the important thing is that to critically appraise a paper, you don't have to be a subject expert. Subject expertise is required because, then of course, you are required to know some of the specific stuff. Basic knowledge of statistics is important, but again, you don't have to be, really a major expert in statistics. This is one thing, and I think I noted it down. And Yeah, I think that's it. That's that's the only thing I would add in. If I remember something, and yes, I would like to really. I feel doubly happy every time this is done. that you people are wonderful. People are not the editors, or you were not the editors of this manuscript. Okay. Thank you very much.
Thank you, sir. And any questions are welcome. Otherwise, we can move on to the next section.
I have a question.
Yes, please.
That in statistical analysis, it is written that data management and part protocol analysis were carried out by the statistician. As per in this part, why did separately mention part protocol analysis? Because then they are coming on the missing data or intention to treat analysis, but they are not anywhere mentioned about all these things. That I have.
No, that's a good thing actually. They have mentioned per protocol analysis. They have at least specified the reason for the choice they have made of per protocol rather than intention to treat. They probably should have explained that, but it's fine enough to have said that
There
an
is
important.
should there is mention of the number of missing data then, if there is part protocol analysis, or how many
That
dropout, how many died, all this.
the results once you have the flow
Okay.
chart for describing study selection, that is where it would be described. So it's not necessary to mention that here, although a per protocol analysis being mentioned here, it makes it likely that there is a lot of missing data, as you have said, that follow-up was probably incomplete. So just unrelated to this, when do you think a per protocol analysis is a good strategy rather than an intention to treat analysis? Is there any particular situation of a clinical trial where a per protocol is preferred rather than an intention to treat? Just a general question to everybody.
When the dropout rate is high, perhaps.
Yes, that is generally when per protocol is used, but then again, per protocol has a potential to give you difference between groups when in real life such a difference may not exist. Intention to treat is a much more, in a superiority trial, intention to treat is a much more conservative analysis. But is there any particular kind of trial, commonly used trial, in which a per protocol analysis is preferred? Or would you all like to find that out? Just go back and read today. We can discuss in the next class.
Okay.
Durga, I had this question. So if you have, when you're using the tense, so it would be advisable to use a past tense when you're writing a manuscript. Is that so?
Yes, because it's already done.
Okay. So everything is in past tense, the same tense.
Yes.
Okay. And if you can just elaborate on this per protocol analysis versus intention to treat, please.
Yes, intention to treat analysis, basically, if you're doing a randomized control trial, you are randomizing into two different groups. Now, intention to treat analyzes only the intention to randomize to a particular group. You have intervention A, you have intervention B. The patient may have shifted from intervention A to B or from B to A, or have discontinued. But you have the outcomes at the end of the follow-up period. You just analyze them based on what was the intention to treat, what was the group that they were randomized to. So here, essentially, if it's a superiority design, you would get conservative estimates, in the sense that unless there is a really good effect size, you're not going to see a difference. So it is more conservative in the sense that you are unlikely to get false positive differences. You are unlikely to get false sense of superiority of a drug as compared to placebo. Unless the difference is really good, you're unlikely to get a positive result on an intention to treat. Whereas per protocol would take into account the protocol deviations. So finally, those who were on treatment A versus finally those who are on treatment B. So here it is more real life, and here you are likely to get a difference between groups even when it may not exist. So your chances of a false positive result are much more. And this situation is actually contrary to what you would want in a non-inferiority trial. In a non-inferiority trial, you are looking for evidence that the two treatments are not dissimilar. There, it is a per protocol analysis that is preferred rather than an intention to treat. In a non-inferiority trial, a per protocol analysis is more conservative than an intention to treat, which actually may show you a difference when such a difference doesn't exist. But generally for superiority trials, it is an intention to treat that is preferred.
Sure. Thank you. Thank you.
Thank you.